Perfect. Welcome to the afternoon session. I'm Oliver Aalami. I'm at the Palo Alto VA in Stanford, and I'm really excited to help lead this next panel, which is going to be very different than earlier, but there's still similarities. We're going to be primarily talking about opportunities and challenges of AI and imaging for precision medicine. And we're going to start off with Dr. Bobby Chang, who hails from Kaiser here in Northern California. He's the Assistant Chair of Vascular Surgery in Northern California. And he comes from a very unique setting, which you'll hear about. And I think what's important, and something we'll get into, I think, in these sessions, is that translation piece that Dr. Zayed brought up. That's really, really important. How do we translate these? Do we have the right incentives? And Kaiser's a unique, being an integrated delivery network, being a payer provider, thinking often about the population, is a really unique setting, not only to research various conditions, but also to actively translate those findings into actionable, preventable programs. So, welcome, Bobby.
Thank you, and I'd like to thank the board for inviting me to speak to this group. The morning sessions were amazing, so thanks. I have no disclosures except to say that most of my research is sponsored by Kaiser in something called the Physician Researcher Program, and it's very similar to like a K Award type of thing. One of the benefits, or some of the benefits of that, are that they're very focused on translational research, and so it's been drilled into me with every research question, there has to be a pathway to implementation, and every question has to pass the so what test. So a lot of what I'll talk about today will be, something that I have proposed that I can implement, if things work out the way I think. So what I'd like to do in the short period of time is to define the current state. In this case, two of my favorite topics, carotid stenosis and abdominal aortic aneurysm. Define the desired state, like where we need to get to, and then figure out how we get there. And for this talk and for my current research interest, they're leveraging AI-enabled image analysis and large data sets that we already work with to enhance a patient-focused risk prediction. So in terms of carotid disease, the current state, for those who don't take care of these patients, is what we do generally is based on historical data. The medical management that goes along with carotid disease has improved a lot since those days. And so there's an evolving role for intervention in carotid stenosis. Currently, patient selection is actually based on the risk of intervention. It's not really based on risk for stroke. So the goal here is to prevent stroke. So what do we know about the treatment options for carotid disease? A lot of what we know comes from trials that were published a really long time ago, as you can see, 1995 and 2004, but it did show a demonstrable beneficial effect for surgery versus medical management. Here you see the number needed to treat to prevent a stroke, or if you flip it the opposite, you can see that there's around 4 to 5 strokes prevented for every 100 CEAs. So that's a number to keep in the back of your head. As we also know, as seen in this very well-known chart by Ann Abbott, the stroke risk in general has been declining over the last few decades, and it was identified by the Society for Vascular Surgery as the #1 research priority. So how did we start? We used sort of the earliest manifestation in my mind of AI that I used for research, which was NLP, to look at all of the patients who might have carotid disease in our system. And this is just a graphic of some nested queries that took us a while to come up with. And then we produced some descriptive papers about what happens to people with carotid disease. And it turns out that their stroke risk is a lot lower than we thought. The usual Kaplan-Meier analysis is 4.7% at 5 years, and if you adjust for the competing risk of death, it's actually lower at 2.5%. And there's just a graphical depiction of that. We then tried to, using retrospective data to do a comparative effectiveness study looking at the use of intervention to prevent stroke. And I won't bore you with the details, but we used marginal structural modeling to replicate a randomized trial. It's just sort of one of the few ways that you can use a big data set to try to replicate what you might find in a trial. And what that does is give you cumulative risk differences. And so this just was published in JVS like in the last month or two. But basically it shows a small but statistically significant beneficial effect of carotid endarterectomy versus not having surgery on stroke prevention out to 8 years. And so if you flip that the other way around, you'll find that if you do 100 endarterectomies perfectly, you'll prevent 3 strokes out to 8 years. And so if you think back to what, a couple slides ago, I showed you the natural frequency metric, which is what that is. It's actually halved now. So your effectiveness of surgery has decreased over time. We also looked at what are the predictors of stroke, and there are a couple that'll come out there. Maybe you can't see that, but if you have a stenosis level and it progresses over time, that was shown to be a predictor of stroke. So what we learned here is that the rate of stroke is low. The benefit of surgery to prevent stroke has diminished with respect to long-term stroke prevention. And it's critical to identify those at greatest risk of stroke. So how do we do this? And is stenosis the correct marker? And I think most of us would probably agree that it's really not. It's the only thing we have right now. And if you look at the European guidelines, which are very much more forward about this kind of thing, they advocate in their guidelines for looking at plaque features, plaque morphology, to identify plaques at risk for stroke. And in our own guidelines, which came out last year, we kind of mentioned that, but we don't go into this amount of detail. And so BK Lal worked with a company that looks at reproducing carotid plaque in a sophisticated way. And he showed in a small data set, I think 200 patients, that you can identify different components of the plaque, including lipid-rich necrotic core, intraplaque hemorrhage, and things like this. And so the desired state is, can we better predict the risk of stroke? And so the research question would be, among patients with carotid disease, does automated carotid plaque analysis predict which patients might be most at risk? And then therefore we could consider for intervention. And so this is, we have a collaboration with this vendor now. And this is a depiction of the CT scan analysis of the plaque, where you can define the lipid-rich necrotic core, calcification, and a bunch of other metrics. And that gives you actually a quantifiable score and all of these different variables. And so for my purposes, if we have a large data set with known outcomes and lots of time-varying covariates, and then we could layer on what we can learn about the carotid plaque, I think that would be great. So we're going to take the cohorts that we've already come up with and utilize that. And so the destination for us would be a more precise predictor of stroke for each patient. So each CTA would be analyzed in real time. This is the dream. And the score or prediction or whatever model we come up with would be immediately accessible to the clinician, the patient, and there would be a shared decision making around what that carotid plaque really means for that patient. And then we could prescribe intervention for those who actually need it. And I don't know, I think the timeline could be 2 years if things work out. I just want to shift quickly to abdominal aortic aneurysm. We all know what this is, how dangerous it is. The current state of AAA, if it's neglected or untreated or just shows up in your office, at a large size, there's a high risk of rupture and death. We know that. So AAA surveillance is really crucial to successful population management. We have a AAA registry, which I'll briefly mention in a minute, but we use it for research, but we also need to improve it. The reason it's not great is that it's based on a derived maximum size from a radiology report that may or may not be completely accurate, may not include the size that we need, so it's not precise. And we also don't know about, AAA natural history from an image standpoint. The current understanding of how aneurysms grow is basically from the rescan study, which was published in JAMA in 2011, I believe. And it's essentially a meta-regression. It's a large meta-analysis of 15 studies going back to the 70s. It's super heterogeneous, and there weren't that many women. And so, but this is the best we have. And all of the surveillance guidelines that we have are literally based on that exact study. And so you can see here that there's some low quality evidence for surveillance guidelines. And the problem there is there's no distinction between men and women or other characteristics about patients that should change this. So we started here with another NLP event to categorize and find the cohort. We were able to find 14,000 patients that are in our registry, and we were able to put them into size buckets in terms of how they entered the registry. And our first modeling was we were able to sort of track sizes based on where you started in the registry and based on gender. And you can see there the dotted line are women. We also can give you time estimates as to, given a starting size, how long it might take to reach an operative size. And this is for men, and then this is for women. So when you think about image analysis, centerline assessment and 3D modeling of AAAs in particular, that's not new. This is many of you familiar with M2S, it used to be called. And this is from, I think I learned how to use this when I was a fellow many years ago. So in my mind, the desired state for AAA work is, can we use source images like that rather than the reported data or something that's mentioned in a report or not mentioned in a report to detect, to surveil, and to understand the natural history? I do believe we need a better solution. And so here we also turn to image analysis. And you're going to hear about auto-segmentation from experts that are sitting right over there. So I won't go into too much detail about this, but this is how we plan to, I don't know if is this the, yeah, so this is one of the many vendors that are in this space that we're working with to basically auto-segment and provide us very detailed measurements of the aorta. You can do this to track AAA volume over time, whether it's pre or post EVAR. And also, by arterial segment. So in theory, we could do a research study on any segment of the aorta, whether it's the arch, the ascending, paravisceral, et cetera. And that is the plan. So the destination where I'd like to be in the next 12 to 18 months is to use orthogonal assessments of AAA in our large data set and validate that we can do it well, and then to move away from a human-powered surveillance tool, which is run by nurses who have to look through reports, to have it automatically done and in just a better way. And then, we have these ongoing collaborations with VQI, this so-called LEAF project that's about to start. And there's a core lab component of that. And I submit that this kind of technology should perhaps replace core lab, and volume measurements and distances from target arteries and top of stent graft could be automatically detected and recorded. Also, the research part of me is really interested in the natural history of all of these pathologies. There's a lot we don't know, and I was telling someone that when I was a resident, the defining paper about ascending aneurysms was done by a medical student at Yale, and he literally took hard copies of CT scans, put it up on the screen, and measured with a ruler. And they wrote it up, published it, and that was sort of the gold standard, and probably still is in ascendings. So with the natural history learnings, we would provide precise surveillance recommendations based on all the other data that we have, identify those at risk for rupture. The sort of really interesting part is using this to perhaps detect disease in general, in the general population. not necessarily people we're surveilling. And again, I think the timeline is short. Where do we go from here? We are close to widespread implementation of this kind of technology in clinical vascular surgery within Kaiser. And our next steps are listed there: validation studies, natural history learnings, and operationalizing all of this technology. Just close quickly, I know I'm over time, I'm sorry, with my thank you to my collaborators. I also just want to give a shout out to Doug Gray, who many of you know. He never changes his clothes. Because he, he hired me, and he gave me the vision on day one that I could do research within Kaiser, and B, gave me a really big help forward about 5 to 8 years ago. And without that, I wouldn't be able to do a lot of this, so thank you.
All right, that was just the start, just the beginning to kind of touch on where computer vision, the richness of all these imaging modalities, what they can provide when we're thinking about precision medicine, patient-centric care. So next, we're really fortunate to have Dr. Sharon Kiang from Loma Linda. She's a chief of vascular surgery there and also associate dean of research, I believe. Vice chair of research. So very excited to hear. You're going to talk about multimodality use.
Thank you. Thank you, everyone, and thank you for the invitation to come speak. So I want to address my title a little bit. What does multimodal AAA progression really mean? And I'm just going to flat out, it's like a hint, we are actually going to talk about the intersection between clinical metrics, image segmentation, and also the use of biomechanics, computational fluid dynamics, and we're going to use deep learning as the main common language between all 3 different lines of data. These are my disclosures. I am funded by the US Department of Veteran Affairs. So we've seen this slide multiple times at this point, but it's always good to kind of refresh. AI is a broad concept. Nested within AI are machine learning, which you've heard a lot about from some of the great speakers today. But today's talk, for me, is going to focus mostly on deep learning. It's a subsegment of machine learning. And what it does is it uses computational neural networks to form nonlinear relationships between multi-nonlinear types of data. So what is AI? AI corresponds to a broad discipline, and it tries to mimic properties of human intelligence. By that, I'm talking about reasoning, learning, adaptation, interaction, sensory understanding, and in our particular field in my lab, we're looking at computer vision. So to really kind of explain that a little bit, we have to talk a little bit about neural networks, and you're going to hear me reference this a lot, so it kind of bears some importance. A computational learning system is a neural network is a computational learning system that uses network of functions to understand and translate data input from one form going in to a different form of the data coming out. So if you think about vision, what are we really trying to do, right? We're taking something that we see, quote, and then turning it into an understanding in our brain. So what we're asking the computer to do is exactly that, to basically replicate the visual cortex. To do that, we have used a convolutional neural network, also affectionately called CNN, and it's a form of deep learning. So if you look at the picture on the bottom, we're asking not the machine to memorize that particular aneurysm with the intramural thrombus, that particular slice, but to actually understand the concept of a AAA, the concept of aneurysm. That is deep learning, right? The computer learning that without a priori assumption. So how is computer vision, what is that language? What does that mean? Because I can use these terms. This is not Star Trek. This is not a movie, so we actually have to break it down. So we'll use the humble kidney as an example. So if you using your eyeballs, which we all are, we can easily tell, yeah, that's a kidney. Like, we understand that. But what does that understanding really mean? How do we break that down? So in computer world, instead of seeing this as a kidney, it sees itself as a shade of gray. And then it sees a matrix of numbers that represent pixel brightness, and it breaks it down into a quantifiable statistical number. Don't get lost in this entire diagram. All I'm trying to show you is then it takes the statistical numbers that it breaks the pixelations down into and turns it into probabilities. So what it's really doing is taking a medical image, transforming it, right? That's its own form of understanding, quote unquote, and giving it a statistical probability to know what that means, what that translates into. We can do the exact same thing in cross-sectional imaging. This is what Dr. Chang was referencing for segmentation. Instead of seeing shades of gray, it takes the pixelation within the CT scan, CTA, for example, in our case, and it breaks it down into statistical probabilities, and then it lumps them into larger quadrants of statistical probabilities that conform into an understanding and translation. So by this, I'm saying it takes a large axial image, it extracts out pockets of statistical probabilities, and they call them kernels, and that's how it understands what it is. And that's what we did in our lab. So to actually do this in our lab, we built a proof of concept convolutional neural network. We used the VGG16 architecture because it's very flexible. It has 16 internal layers of neural networks that allows a good translation for basically identification and classification. We basically processed 12,000 aortic images to train this system, and then we boosted its performance using different forms of augmentation. And what we found was that it was able to predict and able to understand aneurysms with a AUC of 0.99. This is unsupervised, meaning I'm not standing there image by image telling the machine what it is. The machine was able to figure it out, quote unquote, right? And so in order to validate our work and the AUC of 0.99, we went back to make sure we understood that the machine didn't make mistakes, if that makes sense. We had to go back in to break down to make sure the machine's accuracy was a true accuracy. What we found overall that there was decreasing misjudgments as the aneurysm size increases. So basically what we're trying to say is the machine didn't make as many mistakes as it approached 5 centimeters. And we use 5 centimeters as a cutoff because that's naturally where we think the indications for repair should be, right? So that's the number that we chose. We also found that the average thickness of the mural thrombi that caused false negative misjudgments was 12.8 millimeters. And some of these data that I am talking about is represented by the heat maps. So you can see how it wasn't able to capture the true outer boundaries of the aneurysm, right? It couldn't figure out what the thrombus really was. And then what I didn't represent here is when we actually sub-analyzed some of the misjudgments or accuracies of the machine, we found that our system was able to differentiate concurrent aneurysms or aneurysms related to dissection. That's a whole separate topic when we started looking into the data set for that, and we didn't have enough time to include it into this talk. We were also really making sure that algorithm fairness was actually incorporated into our algorithm. So we actually chose to choose one form of disparity, which we chose to look to gender. And we did find within our data set that, you know, the female-only training subsets were not doing as well compared to other 5 subsets of training algorithms. That's a separate topic alone, but we wanted to address it with the team and the group here that we're not blind to the fact that algorithms and architectures can be biased, and that can be inherent to the data. So we're going to choose to address the algorithm fairness with at a separate time, but I just wanted to disclose it to the group that we did find that in our data. So why am I harping so much on this? Why am I spending so much time discussing and explaining computer vision? It goes back to what we're trying to do. So my lab is really focused on creating a common language between different types of data. So just 2 types of data is represented here right now, right? I just talked about imaging data, which is very prone to subjective human analysis. We rely on radiologists, we rely on the quality of the CT scan, we rely on image acquisition. And that, we know, we can look at and figure that out. On the other side, on the far side of your slide, are the non-imaging data, which is your clinical data, right? What was your blood pressure? What was your creatinine? Those type of things. You have your laboratory data, which I just kind of addressed. And in there is the genomic and proteomic data, the large volume of biology, right, that we want to address. And that is part of that type of data that we think about when we write about, you know, retrospective studies, when we talk about that stuff. But if you really think about it, that data is a very different language when we process it compared to imaging data, right? They are correlative, they may be associative, but they're not comparable. We're not even talking about apples to oranges. They're not fruits with each other. You're talking about an apple to like a soccer ball, right? So how do we bring it together? And this is where the power of deep learning happens. This is where deep learning can break all that down into different variations of statistical probabilities within an algorithm. So it is a shared data that is comparable and is data that can actually be processed together. And therefore, we can get prediction models. There's a third data set that I'm really interested that my lab is building on, because I think for understanding aneurysms, and especially the behavior aneurysms, you can't ignore biomechanics, hemodynamics, computational fluid dynamics. So what we're interested is building the engineering component of flow, of resistance, of pressurization outside the sac, within the sac, in different sizes into this algorithm. So we did that. And we did that by creating a fixed system. This is actually a model of, let's say, a saccular aneurysm that we have built. We have violated the law of wall, which means we have created a rigid wall and allowed resistance essentially to be uniform throughout. That was the only way to actually control different variables as we measured. One component we were very interested was focal points of weakness. So we were looking at shear stress, peak stress, and obviously we did it over austere shear indexes, so we can kind of get an idea of how flow is actually going through, let's say in this case, a thoracic aneurysm. So this is actually our data, which we actually built, and then we had to break down. Long story short, we basically measured it over 2 cardiac cycles, and we found that the smaller neck, a deeper sac, and a larger aspect ratio decreased this peak wall shear stress, and that's really important, right? Because there's no other real way to get this data, unless we're going old school and just having a cohort of patients untreated and having postmortem data to see where points of focal weakness are, right? That is not possible. That is not the type of data that we can get in this current age. So we're gonna have to simulate it. And our next model coming forward will be resistive models, where we actually build in the wall compliance and actually different types of perfusion compliance models, right? Built basically working in wall shears and actually the law of the wall that I just talked about, so they're more realistic. But we started with this, and this is an upcoming publication. One thing that we talked a lot about image segmentation is we've talked a lot about axial imaging, but I wanted to bring up something that is very revolutionary right now and very hot, which is looking at fractal dimensions for angiograms. I just went through this whole shebang about how computer vision works, but you can see if you apply the same thing to angiograms, that's extremely hard, if not almost impossible, right? How do you break down the pixelations into statistical numbers, into quadrants of kernels? Angiograms, unlike axial imaging, is not uniform. Acquisition is incredibly heterogeneous. Different ways of actual fluoroscopy, especially machines, are much more heterogeneous than your normal standard CT scan these days, right? So what we're trying to do in our lab is also use fractal dimensions, which is to create probable branching points within angiograms to simulate how an abnormal angiogram should be a normal angiogram, and then take away the parts of the anatomy to create predictive models, if that makes sense. So you kind of have to work backwards on this one. Take bad angios, use fractals to create a normal angio and its variants, and then take out portions of it to see how it differs in the predictive outcomes for limbs. This is a whole can of worms. Different problem, different topic. And we are beta testing some algorithms right now in our lab with angiograms for CLTI patients. So I was told to kind of finish up by asking what's next? Like, now what? Like, I've said all this stuff. It sounds super complicated. And the problem is, algorithms are one thing, but the power lies in the data, right? Algorithms don't mean anything if you don't have the large data to test it on, validate it, and then actually see if it's generalizable. So I think what we need are good multi-center, high-quality data. And before someone asks me, registry data are not it in this type of work. We need good imaging data. We need interoperative data from everyone here. And we need data that is non-contaminated, right? Process data is very hard for true deep learning work to happen because you're already introducing contamination. And that's how bias, data drift, and all that stuff happens. So I think the power lies in all of us here because we are the grassroots people that can actually get that data to make this happen. I think we have to have good predictive models for validation that comes with the data and disease-specific data. And I'm looking obviously at Dr. Milkowitz and the group at Houston because if you look at the connective tissue disorder, that data is so powerful. And we're currently buying a second core system and increasing the number of cores from 8 to 10 because the sheer amount of volume of data is taking my current core system like a week to process. And as more data and projects come through, we just need a separate system to kind of handle the flux of all the genetic data that's coming in, because that would be amazing, right, to understand. I think like the references to genomic data, if we can build a common language, it's more than just understanding how to treat diseases. It's about understanding the biology. So if we look at the aorta, it's really about understanding the behavior of the aorta and understanding the behavior of aneurysms. Behavior right now is extrapolated to our treatments and failure of treatments, right? And that's how we're looking backwards to see, oh, this would have happened if we didn't do this. Or we didn't do this because that's what happened. But that's not really what behavior is. Behavior is understanding why this person and that person may have CFD, maybe that one has VEDS, how they behave all differently, right? Because right now, EVARs are prophylactic, technically, right? What if we can be better at that? What if I can say that this patient, 47-year-old with a 3-centimeter, whatever, that lives 5 miles outside of UCSF, you're probably going to have a 5-centimeter progression to a true aneurysm in about 10 years. And at that time, the angle would be this, your rupture risk would be this, your focal points of weakness would be this, and the geometry would predict would be 97% saccular, something like that. And then instead of just scanning this guy, in the last 5 years of this 10-year wait period every year, we can say, hey, go do your thing. We'll call you in 10 years and then figure it out, right? That sounds promising, and we made a lot of points today that human behavior is not linear. I get that. I understand that part, and that things may change. But what if we have that power to give our patients that type of knowledge so they know what would happen to them? That's it. Thank you so much.
We're trying to stick to the 10-minute limit. Not easy. Too many amazing things to talk about. So we learned a lot about the power of multimodal data and approaches. Next, I'm sure you've seen all those Cruise self-driving cars with the LiDAR things on them. Tesla takes a different approach. Their self-driving automation system is purely based on cameras. And it's based on the first principle that your eyes can see. As we know as physicians, after we put in our 10,000 hours, when you see someone at the bedside from just the entry point of the room, you kind of, within milliseconds, can make an assessment. And Dr. Corriere is going to talk about something very similar, which is a really interesting, fascinating study to assess for resilience in patients using computer vision.
Thank you. I've got a bunch of videos. Are you going to help me cue the videos when I get to those slides? All right. Prepare yourself. All right. These are my disclosures. I want to thank Vascular Cures for having this symposium. I've had my own research for wild ideas supported by them that went somewhere. I'm also, more recently, have become an FDA panelist, and I'm stealing my own thunder because I like being in an innovation segment when they get to, well, what about FDA? And then I'm like, oh yeah, I'm an FDA advisor. I don't advise FDA for AI stuff, but for medical devices, but that's been a useful perspective to gain. As we've discussed already, there's a lot of scenarios in the clinic where we're trying to make a decision about are we going to watch and wait or move ahead and take care of something? Are we more likely to harm or help a patient if we operate or if we don't? And how well does the family even understand what we're talking about? We know frailty is highly prevalent among patients with cardiovascular disease and associated with mortality, complications, and non-home discharge. Putting a patient in the from an independent living person to a nursing home is a really big deal that we don't always predict super well. By the same token, we can't screen every single person like they're super high risk. It results in over-testing, wastes a bunch of money, and in some cases, we become so risk averse that we deny patients, particularly older patients, treatments that they might benefit from based on their age alone. So there's some misclassification going on. We don't really consistently screen for risk within clinical practice right now. We often make decisions in the moment. If I see a patient in clinic, I'm evaluating them for a high-risk procedure. It's going to require a general anesthetic. I don't get their pre-op risk evaluation until after they leave, often after they're scheduled for surgery. And we build up this inertia around undoing that decision if we uncover new information. Why is that? Well, it's kind of two big buckets, too little or too late. The data we need isn't available when we have to decide about surgery. We get it later but don't revisit the risk profile. Bullet point number 3, surgeon doesn't have time to think about it. That's a real world consideration. And we're oftentimes focused on finding just high risk bad candidates. And we don't flip our thinking to say, how about if we can find a good risk candidate that we might save through screening less aggressively. And then the too late one, a lot of the data around frailty and risk is retrospective. It's post-mortem. We identify the high-risk patient after they did not survive what we did to them. So we need to reconfigure and kind of front-load this more. This is a screenshot with the patient's names blocked out of my clinic this week. I challenge you to find enough time to have lunch, let alone go to the bathroom during that. So for this stuff to work in clinic, it's got to be super fast and ready when the doctor walks in the room. So we need to refine our approach to risk evaluation, get the information before we pull the trigger on a bunch of testing or scheduling an operation, and selectively test the high-risk patients and maybe selectively don't test the low-risk patients and reduce deaths. Now, when I started thinking about this presentation kind of shows the runway to what we're doing now, which I think is important. We're studying grip strength as just an intervention that takes literally about 3 seconds. This is a hand dynamometer the patient's holding. We have them just grip it as hard as they can in their dominant hand. That single value, it turns out, correlates with a lot of cross-sectional information about revised cardiac risk index, psoas diameter, Charlson comorbidity. And it also, over time, it turns out to correlate with survival and non-home discharge, regardless if they have surgery or not. So pretty crude tests, but low risk and very high value data. I got a small innovation grant from our cardiovascular center, and we actually made this a discrete data element in our medical record. We've enrolled about 5,000 unique patients in that at Michigan so far, and we've got this text phrase here where if the surgeon or whomever grips a patient, they can drop in the measurement along with this algorithm to kind of risk stratify the patient based on their gender and BMI, which is all sitting right there. Now, there was a huge amount of interest in this work picked up by AARP, US News, et cetera. But we were presenting this at a meeting, and this is a quote from Adam Beck, who's the chief of vascular at UAB, at the coffee break after one of my talks. And he's like, I don't need this. I know what risk looks like. If I have a patient with thoracoabdominal aneurysm, I can just tell them to get up on the table out of the chair and watch them do that. And if they can't do that without help or they do it a certain way, I inherently know if they're high risk or low risk. And if you're a vascular surgeon in the audience, raise your hand if you feel like you have a good gestalt of what a high risk patient looks like. Okay, all right, most people admit it. I think I do too. But is there a smarter, more objective, easier, faster solution? What if we took a little smartphone video of that transfer task? This idea came from that challenge at the coffee break. And could we use that to predict risk? This you may be familiar with. It's called horse in motion. It was actually taken from a set of photographs filmed on a track in Palo Alto. It's really not the first movie ever, but this is up here to cue us in. And we take a video. We think about analyzing a video. It's really just a series of sequential images, not unlike a CT scan rolling through a patient, and we can break that down and analyze those an image at a time. This is me posing for this. Our IRB required this, but our initial approach to this is we're going to get data out of the EMR about comorbidity. We're going to measure their grip strength, and then we're going to segment that transfer task that we film into these pieces based on the timed up and go test, which is a geriatric test, and see how that correlates. And in our initial iteration of that, we were using a manual coding of the video. This is a software program called MaxQDA, and we would literally frame by frame, you can see there's a timestamp there, so we could get the time for each segment and transfer task. We could also get a bunch of qualitative appearance things about the patient. Like you could see this patient's wearing glasses, he's got suspenders, not a belt. And look at not only how the patient moves, but how they look. So I'm gonna have you cue, can you play the video for this? There's gonna be a bunch of these. Watch this patient move. I'll tell you, I'll narrate while he does it. Hopefully it's gonna work.
Whatever you want.
He's got an orthotic shoe on. You can see he's got sweatpants on. He has no laces or buckles anywhere. He just rocked a little bit getting out of the chair. He's going to put his hand out on the wall before he sits down. So a lot of different cues from that little piece, a huge amount of data sitting there. I'm going to just roll through a few examples. Here's another one. Now, this patient starts seated in a wheelchair. You're going to see him transfer to the table, but I'm already getting information when I walk in the room that he's in a wheelchair. Sorry, I thought I was going to be able to cue these from up here. I should have checked.
Let me make sure. Okay, whenever you're ready, sir.
You'll see he's got an untucked shirt hanging out of the back of his, he has to rock to get out of that wheelchair. As he turns, if you're looking closely, you'll see he's wearing an insulin pump. He's going to put his hand down to find the bed before he sits on it. That untucked shirt is a sign of addressing apraxia. That's a stroke risk evaluation tool. Keep going. This is another video. Thought I'd wake everybody up.
Ready.
Watch how differently this patient moves. He gives us almost a figure skater pirouette there. He chooses to sit down sideways for some reason. We didn't tell him which way to face. Next video.
Okay, whenever you're ready.
Okay, looking at this patient, you might say, boy, this patient looks like she's obese, but she moves pretty good. Is she frail or not? So what did we find with this manual coding? We did this with about 30-something, 40-something patients, and it turns out if you're frail, based on the objective data, that transfer task takes a longer time. And qualitative factors associated with increased risk include using your arms to get out of the chair, needing to balance yourself before you start taking a step, reaching out ahead of you to touch the table before turning or sitting down. And then the qualitative factors that were related to the patient appearance include things like wheelchair, orthotics, walker in the screen, unkempt appearance, lack of buckles, buttons, laces, or zippers. So my resident Glory Kim was presenting this analysis I just showed you at the Georgia Vascular Society. And here's another great question from Scott Stevens at University of Tennessee, Knoxville. He gets up at the mic. He says, hey, my brother-in-law runs a security company, and they basically use AI to watch a parking deck video for them without a person having to do it and figure out when there's crime going on. Why don't you do that? So that's where this thing I'm about to show you came from. So next step, could we upload that video, automate the analysis, and automate the categorization of the patient's risk status based on a library of phenotypes linked to videos with data derived from measured variables like that grip and EMR data and demographic data, and spit you out an answer. And again, we're not just interested in identifying the high-risk patient where we want to opt out, but also the low-risk patient, because a lot of surgeons see, just like we can identify a frail 82-year-old, we can also see an 82-year-old that looks like they're pretty fit, and we're seeking some kind of confirmation that they're okay to go ahead. I had a bunch of naysayers early on, and we struggled to find the right people to do this coding. You can't do that. You need thousands of videos. Some people thought, a geriatrics collaborator of mine, you need an identical visually clean environment in every video with a green screen behind it. Well, that'll go nowhere. The camera can't pan or move. The entire patient must be visible at all times, and you're going to get screwed up if you're mixing portrait and landscape orientations. We got a small grant from the Michigan Surgical Innovation Accelerator project for this. I thought we were too early, but someone at Michigan heard about this work and asked me to apply for this, and I really appreciate that. And they basically kicked us in the rear end to look harder. And we finally did find a coder. And I think the most important thing from our customer discovery is this very last bullet point. I thought if you were going to monetize this, it'd be an app that you license, but they said actually the data and the algorithm and linkages of the clinical data is what's unique, because this motion detection isn't much different from what you get at Golf USA if you go to have your golf swing analyzed. So here's our prototype development. I'm not going to read, this has been approved by my computer programmers that help me with this stuff. And things that we've learned so far is the things that decrease accuracy of the AI task segmentation. If you have another person in the room, it'll try to track them instead or merge them with another person if they cross in front of them. If you put a purse in a chair, it'll try to track the purse until the human starts moving. And actually, some of the other stuff really doesn't matter much at all. And the segmentation approach I had proposed initially is probably too simple. Some patients start stepping before they get out of their chair. So another few of these, and I'm just going to let these walk through. They basically use the patient's joints, and they predict center of gravity and try to get the automated analysis to just basically pick up on the moving patient and segment this task. Can you play this video? So you can see and this is kind of brought down to slow-mo, but does a pretty good job. So you see his head's cut off there. You'll also see as I show these, we're using a couple of different clinics to get these patients where the stuff on the walls and the chair and table orientation is different. Actually, he does a fairly reliable job tracking this gentleman and getting into his chair. So now we got a portrait orientation, same clinic, this female patient. Go ahead and play that if you can. Again, remarkably reliable tracking of this task from the chair to the table. This person did a better job keeping the patient in the frame the whole time. There's tons of qualitative data there I won't get into. Here's another one that's really challenging, and to me, this video, it's going to demonstrate the AI tracking, but this is what frailty looks like to me. This is frailty you could see coming a mile away. You can see she gets out of a wheelchair, both arms, puts her hand out to find that table way ahead of sitting down, and you can see she gets out of the frame, back into the frame. She's about to turn her back completely, and it does a remarkably good job of not getting confused and tracking her through that task. You can see she had to hesitate and rock to get up on the step, okay? Here's a final one from my Brighton, Michigan clinic, which is an outreach clinic, which just shows, so now we're landscape orientation, there's a computer in the way, and the layout's completely different, but it's the same algorithm and does a fairly good job tracking the patient out of the chair and onto the table. Yes, we want you to get up and get on the table. I'm a little over, I'm gonna sprint ahead. So this is phase 2, hit this one. This is a video from our collaborating site at Wake Forest. And you can see there's a second person in there, and you can watch, this is gonna move slowly, but when she gets up and crosses, it'll try to merge her with her family member in the room. We've got her face blurred. That's what I was mentioning before. We got challenged by an IRB. And you can see at the top, it's showing us alternatives for a 5 code versus 3 code of how they separate. So it's literally showing you during each phase what the algorithm thinks, which component of the task the patient is engaged in that particular frame. And as she moves across, you're gonna see it gets a little confused and tries to fuse her with her family member's leg. See that? So that's one thing we've learned about cleaning up. But really dirty environment behind her, desk, screen, bunch of papers, and again, she's gonna turn her back, and it tracks her pretty reliably through that task onto the table. So I've already kind of made I'm gonna wrap up because I'm running late. We're planning for intellectual property. If anybody wants this slide, there's a really interesting video about whether these things need regulatory approval. The spin-off use for this is we've got all this video data and all this clinical data now, and I have a couple mentees that are very interested in using this to evaluate for implicit bias, where we let physicians look at the video and we know the answer and have the physician rate the patient. So a lot of exciting stuff. I want to thank my research team who are here and Vascular Cures. And I thought I added the questions, Lisa, last night, but they didn't make it up here, so don't pick on me anymore. Thank you.
All right, awesome. So you get to see how much information is in images and such. And so now I was super fortunate to have Dr. Akshay Chaudhari, there he is, perfect, join us. He's actually from the he's an assistant professor in radiology. And so he lives and breathes this stuff all day, every day. And the challenge I gave him was to talk about operationalizing these things. How do you operationalize them? Or what do you think about when you think about operationalizing them? And also, he's on the forefront of generative AI. He may touch on that as well.
Thank you, Oliver, and thank you for having me present here. Let's see if I can figure this out. Maybe. No. Green button. Green button. Yes, there we go. Perfect. So here are some of my disclosures. None that really affect the content of the presentation, but I think my biggest disclosure for the day is that I'm a PhD scientist and I'm not a vascular surgeon. So pretty much take everything I say with a huge grain of salt. But what I'll really be focusing on today is how do we think about really large data sets? What sort of deep learning algorithms should we be creating? How should we think about sharing these algorithms so that we can run the multi-center validation studies? And towards the end, I made a list of a few notes and topics that came up today that I'll try to briefly cover at the end. So I just wanted to start off by saying that medical imaging data is really vast, and I don't think I need to belabor the point here. But if we look at all the aggregate data that's created by radiology departments across the country, we're generating petabytes of imaging data. So this data can come in different forms. It could look like a lot of different things, lots of different anatomies that are represented. But I think the way we traditionally look at these images and analyze these is only looking at a specific clinical indication in mind. But there's so much additional information that's present in this. Why not use this as an opportunity to quantify things beyond that indication itself too? And perhaps this could be a really nice opportunity for precision diagnostics and to be able to look at diseases before they even manifest, before patients even present with symptoms. Because if we don't utilize what we have, I'd argue that we're wasting a lot of the capacity that we're just sitting on and not really making the most out of it. And within this notion of potentially using radiology for population health, I wanted to flash this slide, which basically talks about the volumes of different imaging studies that we see within the US. And I'm picking specifically CT scans here, because CTs are the most common volumetric imaging modality that are performed. And if we zoom in on one particular anatomy that's focused on, is that abdominal and pelvis CT scans account for roughly 20 million unique individuals in the US who undergo an imaging study per year. So this is a huge corpora of data that we're on, but I wonder if there's better ways in which we can analyze some of the latent information that exists within these scans. And what might one actually look for in some of these images? There's a whole host of different biomarkers. I think that should have been a movie that's not playing, but in any case, it's a big stack of CT slices. There's around 500 slices per scan. So there's just a lot of information that we have to be able to dig through. And this is not really amenable to manual analysis. And we heard a really nice presentation earlier about how deep learning can really enable extracting insights at scale. But right now, still our interpretation is limited by specific clinical indications. And if we look at a lot of the organs that are actually represented in these CT scans, I feel like this is really an opportunity to look at a whole host of common disorders that affect older populations within the US. And specifically, if we zoom in on the top 10 most common disorders in older populations, there's quite a few of cardiometabolic disorders. So we have things like hypertension, we have high cholesterol syndrome, diabetes, ischemic heart disease. So could we potentially target a lot of these disorders using the imaging studies that we're performing already? And this is exactly some of the projects that we're trying to focus on within the lab. So I'm going to talk about one specific pipeline that we're developing to look at CT scans that are required for arbitrary purposes, but then repurposing that information for trying to predict the incidence of future ischemic heart disease. So that pipeline can look something like this. We can take an abdominal CT scan. A patient could come in for arbitrary reasons again. The patient could have an indication of pain. They could be a follow-up patient for an oncology treatment. It doesn't matter. We take these images, we do some post-processing, and then we can quantify specific body composition measures that we know might be indicative of future disease. So here, we're specifically looking at things like how much visceral fat a patient has, what is the skeletal muscle indices that they have, how much subcutaneous fat, and then we extract and combine all these imaging biomarkers with information that's available in the patient's medical record itself too. So it's really trying to combine these disparate data sets that we already have access to. We're just trying to combine them in a new manner. And by performing this multimodal data integration, we're trying to predict what is the likelihood that a patient who is healthy today will go on to progress to something like ischemic heart disease in a 5-year time frame, in a 10-year time frame. So here are some of the results. I don't really want to bore you with the nitty-gritty details, but what I think is interesting here is if we take our standard instruments, such as the Framingham risk score, the pooled cohort equations, we get something like 0.7 AURC curves, relatively low precision recall values. But then if we take some of our opportunistic imaging measures, so if we take some of our CT scans, we combine them with medical records, we combine them with information from our segmentation, we see a substantial improvement in the precision and recall values. So I think this is a really unique opportunity to be able to take these aggregated data sets and really look for relationships that we've never really considered looking for. And the other opportunity that this provides is a little bit of interpretability too, as to what might be some new biomarkers that are really driving some of these changes that might happen in a patient as they progress through a disease. We can do this at a cohort level. So in our cohort that used around 10,000 patients who presented to Stanford for an abdominal CT scan, at a cohort level, we saw some of these variables being most significant and most prognostic for patients progressing to future cardiometabolic diseases. So this is at a cohort level, but we can do this at a patient level also using some of the new explainability tools that we're building. So for a given patient, in this case, a particular diastolic blood pressure value would be low. So this is reducing that patient's risk, but then there's a whole host of additional features that increase that particular patient's risk. So for this particular patient that was in our test set, the PCE, the pooled cohort equations, actually suggested a very low risk, but then our model suggested a substantially higher risk, and the outcome for this patient was indeed developing ischemic heart disease within 5 years. So I think we can aggregate and analyze these large multimodal data sets. We can generate new insights about what might be the underlying physiology that's driving some of these new diseases, and we have a potential to really make intervention-based decisions at the patient-specific level. So hopefully a lot of potential here, more validation to be done, but hopefully we're setting a nice precedent to be able to do this. Building upon some of this work too, we wanted to go beyond this notion of ischemic heart disease too. So a lot of this work is done by Louis, who's sitting right here. He's the expert, so ask him all the hard questions at the end of the talk, not me. But with the same paradigm of using images that we've acquired already, are there other disorders that we can predict? Why limit ourselves to just ischemic heart disease? So we looked at other cardiometabolic disorders like chronic kidney disease, diabetes, et cetera, and we saw substantially high performance for all of these different disorders. So are these systems ready for clinical use? Definitely no, but the fact that we see such high results definitely suggests that there's biomarkers that are present in all these studies, and if we take another lens for analyzing these images, perhaps this is an opportunity to intervene in patients a little bit earlier. So I think a lot of potential with these opportunistic imaging approaches. And what I think is really important to be able to validate these tools is by having availability to run these models across institutions. We heard a big need to be able to share data, but I think we've always needed to share data for the last 10, 15, 20 years. This is not necessarily a novel concept, but it still doesn't happen. So coming from a machine learning-based community where sharing models, sharing data sets is pretty much the norm, I feel like we have a lot of potential to be able to just share some of the models that we developed too. And I think that's a major tenet of a lot of the research that we do in our lab. Why not open source our data? Why not open source our code? Because it's hard to have these large-scale multi-center validation studies because data sharing agreements can take months, lawyers get involved, you don't really want to do it. So why not just avoid that process, share our algorithms? And that's what we really try to do. So Louis has built out this really nice platform called comp-to-comp, computed tomography to body composition. We're scientists, we're not necessarily creative. But with this particular platform, anyone can go online and anyone can just start using a lot of these models that we've built. And I think this is going to be essential so that we can actually validate whether a model that we've built using data from Stanford works at UCSF, whether it works at Mayo. Will it work on the first attempt? Unlikely, but I feel like once we start building out these iteration cycles, we can create higher quality software and create higher quality models. And within this open source comp-to-comp platform, there's a whole host of biomarkers that you can automatically acquire. So your input is just an abdominal CT scan, and your outputs can be multi-parametric. So on the left side, we're seeing here, we can automatically analyze bone mineral density. So where all of these segmentations are generated with our deep learning model that's completely available, we can estimate what the bone mineral density is, push button. Here in the middle, we're automatically trying to compute metrics that relate to the skeletal muscle as well as the adipose tissue. we're really interested in using some of these measures to quantify things like frailty. Things like sarcopenia are severely undercoded at multiple hospitals, including your own. So can we have quantitative measures of frailty? And with some of this analysis, we can do this at a population level. We have some other organ-based metrics here. We're trying to look at the morphology of the liver, the spleen, the pancreas, and maybe we can use some of this information to better understand things like, does my patient have steatosis? Do they have a fatty liver? And all of this is really a push-button approach. This can be run on every CT scan. And we've been able to run some of these analyses at a scale of 25, 30,000 patients within their institution. We have connected all this information to the patient's medical record so we can really see the progression of what might happen to them. So it's really a nice opportunity for precision health at a population level. And I think one feature that might be particularly exciting for this particular audience is we have a nice new open source module that allows you to do things like track AAAs on every single CT scan that comes in. So this was work done in collaboration with Oliver and his student, Adrit. And again, this is the output that you can generate just using 2 or 3 lines of code. It takes around 30 seconds to run. And after a CT scan is performed, you can generate a really nice visualization like this that looks at all the different slices that includes your aorta, and you automatically get these volumetric measurements. So again, the premise here is we have this data. Let's try to squeeze as much information that we can out of it, and let's try to look at these patterns in a way that we haven't looked at before. So we're really excited to see where some of these features can go. So in conclusion, hopefully I've talked about this notion of using opportunistic imaging to be able to look for precision diagnostic measures so that we can start treating patients even before they present with any major symptoms. And we really think that open sourcing a lot of model, creating open source software is the path forward to be able to run these studies at multiple different institutions and to really validate these methods. And there's a lot of really interesting clinical outcomes and questions we can explore. And I just want to talk about a couple of other things as it relates to things like generative AI that we've been talking about. In terms of a lot of the deep learning methods that we're building, it's really taking advantage of all the advances that we're seeing in things like natural language processing, computer vision. If you would have asked me 2 years ago, I would say that NLP and computer vision are completely separate fields. Right now, they're mostly all the same. I think there's a lot of crosstalk in terms of the methods that we're building. So everything that we're using based on how do we train GPT-4, those are the exact same insights that we're utilizing internally to build some multimodal models. In radiology, we have the opportunity to work with imaging data. We have the opportunity to work with medical records data. We're building a lot of tools to be able to analyze clinical notes. We're building NLP-based methods to be able to summarize the problem lists that patients might have. We're using NLP to be able to do better than ICD coding to understand, does the patient actually have a particular disorder? Can we sort through our notes and try to look for disease incidents better than typically used code? So I think there's a lot of potential that these generative methods can provide. And I think it's really up to us to think about what are the questions we should be focusing on. How do we use those insights to build the highest quality models? And then how do we really validate that they're working well and that they work well across institutions? Because there's a general awareness that just because your model is cleared by the FDA doesn't mean that it will work at your particular site. And this is something that we're seeing across multiple different use cases, across multiple different models. So I think being able to validate robustly will be key to unlocking some of these questions that I talked about. And would be happy to work with anyone here to be able to help push towards that. So thank you.
All right, I think the last point was really pertinent to locally validate your risk. Even with risk scores, we've noticed that at various sites you can have very different responses or results. So I'm going to run through, we don't have much time, I'm just going to run through this real quickly. We've talked a lot about high-tech, different ways of personalizing and providing patient-centric vascular care. And we kind of started the day today with a very personal story from Katie. And I think it's appropriate also to come back to that and say, humans in the loop are important as well. We have computers, we have all these fancy things, but when it comes, and I'm going to use the SET program and describe how, cognitive behavioral therapy or techniques were incredibly impactful in a study that we did. So here are my disclosures, and we're working on some home-based programs now that haven't been launched yet. So like I said before, we've talked about polygenic risk scores, we talked about computer vision. These are all really impactful and an aspect of precision medicine and patient-centric vascular care. But I'm here to just argue that when it comes to behavior change, and this is, I really specialize a lot or focus heavily on digital health. And that's basically connecting with the patient, the connected patient at home, outside of the four walls of the hospital. And it turns out for a lot of the chronic conditions that we have, whether it's diabetes or congestive heart failure or things like that, it turns out cognitive behavioral techniques have been quite successful for many, many different diseases. And in particular, I'm going to talk about SMART goals, which we used in our study. I don't have to tell this audience what PAD is, but patients that have PAD, in the guidelines, supervised exercise therapy is one of the top recommendations. What's paid for currently is an in-person program, which is great, but very few exist. I'll be frank that we don't even have a program at our institution for PAD patients. Even the Society of Vascular Surgery published this appropriate use criteria stating, of the over 2,000 cases that they reviewed, the exercise therapy was the first recommendation, so it is widely recommended. And this is based on a lot of data. This is from the Netherlands showing the 2-year freedom from intervention in patients in the Netherlands where they have a very well-established, it's called claudication net exercise therapy program. They were also able to show that at 5 years, they had much higher freedom from revascularizations. So really profound data. And even Dr. Arya, who's here in the audience, along with Elizabeth George, who's now faculty with us, also reconfirmed, and this has been shown in multiple other studies, that with revascularizations comes a higher risk of amputation. So we have all these. The data is there that this is necessary and useful and beneficial, and this is from our SVS several years ago, yet only 860 people received SET in 2019, compared to the 98,000 patients who underwent interventions. And this was, this made national headlines in this New York Times article recently. And there's still quite a bit of debate about the details of this information. But having said all that, one of the biggest problems when it comes to exercise therapy is just lack of access. I mean, physicians want to offer it. Over 98% or almost over 97% said they would offer it, but they just have a hard time, either because there isn't a program, there's no reimbursement, it's hard for patients. So there are many, many challenges. And when it comes to the reimbursement, unlike the cardiac rehab, there are only facility fees provided, no physician fees, even though they require it for an in-person program. So it's just an underfunded program, and that's one of the big issues. And Mary McDermott is a huge, huge proponent of this. She's out of Northwestern. She's studied home-based programs for many, many years. And so there have been some positive trials, some negative trials. I can't see my little thumbs up. Oh, there it is. So, there have been positive trials, some negative trials with kind of varying approaches in terms of how they engage the patient. Some are fully remote, some are not fully remote, some require the patients to come in for 2 weeks, some not. Some had a Fitbit, an accelerometer you'd have to put on, take off. So there are many, many, many different programs that have been trialed with kind of mixed results. This is a kind of a more recent study from 2021 where they had weekly, so even if you talk to Mary McDermott, she admits that weekly coaching is critical to have a good result. And also in this study, something that she noted is that coaching towards higher intensity activity was very beneficial for patients where they had better walking results. So we, a few years back, did with the help of the Society for Vascular Surgery, did our own study of a home-based exercise therapy program, and it was all mobile. And what we tried to emphasize heavily was this whole idea of live behavior change coaching. And this is kind of what the program looks like, where it's physician prescribed, you're diagnosed with PAD and claudication, and you get a set of education, an assessment. But what's unique is this goal setting with the live coach, and it's setting a SMART goal, and I'll get into that in a little bit. And then after that, once the program goes on for 12 weeks, you get weekly coaching, usually by phone. So we're able to onboard about 139 patients over 20 sites. And again, the emphasis is on this army of coaches. They're certified health and wellness coaches that use fairly well described and defined cognitive behavioral techniques, such as motivational interviewing, and part of that was setting this SMART goal that I'm going to describe here. So it's really, it's very simple, but it's actually very profound, and it makes a lot of sense for patients because, and I'm sure you've had the experience with your patients where if you ask them, what is your goal? For one, it's to go fishing. The other, it's to go spend time with their grandparents. The other, it's to go shopping. And each of those goals, they're very different than, let's say, standardized, like, oh, yeah, I need to walk this many meters over this period of time. So that's not a very precise way to approach things. So these SMART goals are specific, measurable. So what is it that, how will you know that you've achieved your goal? Is it attainable? You want to make sure that it's attainable. Is it relevant to what you'd like to achieve, and what's the time frame that you'd like to achieve that goal? And just setting this goal, believe it or not, we had patients set 3 of these goals, not just one, was quite impactful. Here are just some examples. We did achieve about 86% of the original goals that were met. It could be longer walking, sustained walking distance without pain, independence, being able to work on their hobbies, spend time with family, things like that. Obviously, there are always challenges, and part of the coaching helps them identify the challenges and also come up with good strategies to overcome the challenges. So not rocket science, but again, it's just sometimes it doesn't take rocket science to have a huge impact, and behavior change, especially for patients that have claudication, is quite impactful. So I just wanted to emphasize, the kind of profound impact that this sort of health coaching and setting SMART goals had in our study. And it's something that I think should be considered in other programs. And this is true across, not just for exercise therapy, but all the other chronic conditions where health coaching is involved. I'm going to stop there because we're really short on time and we need to start the panel, but thank you very much. And then if the panelists could come up. I think we have until 2:45. We're not doing too bad. I guess we'll all sit down. We have enough room. All right. All right, perfect. So that was very different than this morning, but I want to start off with what Bobby, with what you started with, the whole "so what" question, because there's a lot of discussion of very kind of complex technology, that could cost a lot of money, takes a lot to implement, and you talked a lot about integrating it into the workflow. I wanted to just hear from you and maybe the other panelists as well, about this the importance of the "so what."
Yeah, I think part of what I do is a reflection of sort of the job that I have. I'm primarily a surgeon and also a researcher. And so the work that I get asked to do or I get involved in at some point has to be translational. And I have to be able to explain to the people who support me that there is a clinical impact that is like right around the corner. So I really, I'm so impressed by the work that the other panelists or the other speakers are doing, because it's so visionary, and it's like you can clearly see the road out there and all the work that it takes to get to an answer, and then it begets more questions. Yeah, so for me, when I think of a clinical problem, I immediately just try to find the easiest, cheapest, most nearby solution. And sometimes it's not the best one, and I've made some mistakes where I've tried to work with something that I thought was just the one that was right next door, and I have to maybe be smarter about that.
What's a good time frame? What is, when you say translation, what is acceptable, an acceptable time frame? Because I think we all have the dream that this is translated.
I think it's been defined to me, at least where I work, it's within 4 years.
Okay.
Yeah.
So that's pretty generous. I want to, if there are questions in the audience, please do. Yeah, Mohammed?
So 2 questions. There were some variable opinions about how to protect your code. I know Dr. Corriere said that he wanted to patent it potentially, and then I've heard also from Dr. Chaudhari that you wanted to potentially make it open source, right? And so, what are your differing opinions on this? Like, how do you still protect your technology and potentially license it, commercialize it, but at the same time be able to disseminate it and have others use it? And then a question to Oliver: why don't we have reimbursed set? I mean, what is?
I'm not a politician.
What is,
I need to go to DC for that. No good.
So the fact that we're here with a nonprofit organization here and others that represent us at the AHA, what would it take for organizations like Vascular or AHA or other foundations like that to be able to make an impact and have policymakers reimburse for what looks like an impactful method to treat patients?
Those are great questions. Well, let's start with the first. I don't know if Akshay or Bobby.
Sure, I'll be on team open source. I think it's just the way we think about it is what is the scale of impact that you can potentially have. Seeing a lot of the advances that we're seeing in the machine learning community, everything has been enabled because models, code, and all software infrastructure has been available, so that if a new model comes out today, I can evaluate it on my data sets by the end of the night. So I think that's a really big opportunity. One of the biggest success cases that we've seen is we've been involved with some similar work that was presented by Matthew about trying to understand how people move in the wild. So we collaborate with a biomechanics researcher, and we can actually integrate kinematics as well as kinetics. So in addition to understanding, well, what is your knee flexion angle, we can ask questions like, how are you loading your joint? What is your knee adduction moment? What is your hip adduction moment? And we open source that model, we call it OpenCap, and within 6 months, even before the paper was published in a journal, 200 biomechanics labs across the world have been using it. There's 500,000 trials that have been performed with that in unique patients. So I think open sourcing can have a lot of impact, and specifically within deep learning algorithms, I think it's really hard to have patent protection, because deep learning and all algorithms, I think, are very easily being commoditized. So just because you have a patent on an algorithm today doesn't mean that tomorrow there's not going to be a different method that will make most of your claims invalid. So at least that's our philosophy, but it'd be interesting to hear other perspectives.
Yeah, you should go, but I think it's really important to differentiate between the data and the algorithm. Like, the data is gold.
Yeah.
Right? And you probably hold on to your data. I mean, there are data sharing, there are open source data sets, but go ahead.
Yeah, and I'm not a business person, and I just want the stuff to get done. So, like, the innovation program felt very strongly about exploring that side. And I got to say, there was tremendous interest. I met with someone from Blue Cross Blue Shield who we ran out of time at an hour. But a big through line of my research is I really like novel data elements that other people aren't collecting. So someone validating this model locally would need to get a grip on that patient, which most people don't do. It's not hard to do. I also would say it's remarkable to me, having run my first little, flirt with the business sector, how much more willing they are to move ahead quickly. and trying to explore this problem with some of my colleagues in geriatrics at Michigan who are very expert and know a lot. It was almost like they were trying to stop us from getting this done. I had a geriatrics colleague who said, well, first you're going to have to take all the patients and put all these little dot markers all over their body, like the guy that played Gollum in the Lord of the Rings movie CGI thing. And I was like, that's never going to be something we can do in clinics. I've always been very focused on in clinic at bedside, and I think it was very helpful to have that perspective about just moving forward, accepting you don't know everything when you begin. And I'm ultimately not sure if it will be a product or not. We haven't patented that, and we are about this far from a demonstrable phenotype, which needs the linkage to the clinical data elements is the next step, which we thought was going to be the easier step, and we're way ahead of schedule.
Just back to your original question, though, about open source and codes and algorithms. So there's actually a third possible way, right? We talked about open source. And then I think it depends what your vision is and what your goals are, right? If you're actually going to go, find investors and actually develop a company, that's one thing. If you're going to open source it within the PhD data scientist world, they're all like that. They're all like these giant, open-minded, generous people that are willing to help you. I think there's a third complexity we haven't talked about, which is the IP, and actually if you're working in the VA hospital. So I chose to get around that by housing it under as research, and I went ahead and published the code, the Python code itself, within the manuscript as a supplemental. And our goal was to get around the proprietary rights of the VA, right? Technically, it's an invention under the federal premises. And our goal was actually to allow people to use it, just as everyone alluded to, the generalizability of the code. The code is worthless if the data isn't there to validate it. And our vision was bigger than that. It's not just about Sharon Kiang making a business model for myself. We wanted everyone to use it. Now, obviously, we're on our 12th iteration of the code at this point because we've actually moved on from the original classification model to actually now the deeper learning predictive models. So we'll be, and in full disclosure, we'll be publishing that too, under the research umbrella. So not violating any sort of IP issues with the VA.
I was just going to make one question and comment. I mean, I would agree with everyone. I think the codes, the proprietary nature of codes is going to change dramatically. There's not much there. I think it's going to be the data, and to be very frank, just like our phones, which app do most people use? So if you want to really change practice, what can you put in front of clinicians that they use the most? And then the race will be to the code backend, but the people that have, I'll call it the hardware to get in front of clinicians will be important. I guess I'll ask the question about supervised exercise training. Medicare went through a long open period where we did get at least cardiac rehab turned into 6 indications, which includes PAD for supervised exercise training. But the problem is it's not close to where people are. So I think one through line for some of the research programs and potentially the public, I'll call it advocacy, coming out of the pandemic is how do you do healthcare, especially in conditions like peripheral artery disease, closer to people with some sustainable model. And it'd be great to study those because what the CMS would come back and say is all those trials were in these clinics where people were observed, and they did that. Mary McDermott does have evidence, but we want to see, reproducible large evidence that leads to, I'll call it a payment and decision.
Perfect. Katie had a question.
Katie, just a sec. Sorry.
Not really. Sorry.
Hi.
Hi.
I have a question for you, Sharon. It was really interesting seeing your presentation on deep learning and how it relates to prediction of aneurysmal growth, and that's my understanding as a patient. That's what I took from it. What was really my bigger question do we have good enough imaging methods to take that further and use that kind of approach to try to predict where a patient with a very spontaneous kind of phenotype that dissects without aneurysm? Do we have the imaging modalities available to use that kind of learning to kind of predict where the next thing we should be looking out for is?
Yeah, that's a great question. I think medical imaging has come a long way, but I think we're still light years behind, right? So as I alluded to in vision, what we see is already an interpretation when we have medical imaging in front of us. The computer, the algorithm, sees way more than what we see. So I think in learning how to understand computer vision, we're going to learn more about not only what other information is there, but also the limitations of what we're interpreting. What I've learned, crazy as it is, I'm teaching the machine's teaching me. I've learned way more of how much I don't see teaching and building the algorithm for it. So I think what I'm trying to say is, buried within with what we have, there's way more volumes of data that we're not understanding. We're not seeing it because we are limited by our finite interpretive abilities for ourselves, right? As surgeons, as the surgeons in the room, we're incredibly results-driven, we're incredibly linear in how we see, let's say, disease processes, biology. But in reality, that's where the deep learning comes in, because they will extrapolate all nonlinear based data points and connect them together for us and offer us possibilities without exhaustion. And I think it's going to be an exciting time. And there's going to be a great way to do it, and then there will be some ways where we're going to have to live and learn and see this is probably not the best way. But I think the data is there. We're just limited by our own eyeballs.
So I'm excited to see where that goes, because I think that's something a lot of people with VEDS and similar conditions would be interested in. Thank you.
Thank you.
That was a great question. I have a question just for all the panelists, and anyone can answer, but as we move towards operationalizing these models in health systems and clinics, who should own it? Should it be the Department of Surgery, the Division of Vascular Surgery? Should it be radiology? Should it be, who should own it? Who should run it? Who's going to pay for it?
Why do you ask these hard questions? I was talking about hopes and dreams. I'm going to hand this one off to someone else smarter.
Well, you must have had some experience. I know Akshay can speak from, because I know at Stanford we talk a lot of talk, but do we walk the walk?
I think we're trying to. I don't think I have all the answers, and hopefully my chair's not listening. But I think it really depends on what the indications are and what the intended use is. So with something like opportunistic imaging, where we're just analyzing every single CT scan that might be coming in, the way our model is working is when we think about deploying some of those algorithms in the clinic, we actually ask our clinicians, is this information helpful? How would you use it? What set of patients would you use it on? And then we really ask the specialists to make a request to radiology to incorporate a specific algorithm. And then radiology goes to work saying, okay, if this is your given need, here are 2 commercial algorithms that we can buy. We have one in-house algorithm. Let's evaluate their performance on the metrics that you care about. So it's a multifaceted process just in choosing which algorithm gets deployed based on clinical needs. And then once we deploy an algorithm, how do we actually monitor that it's working? Because most algorithms don't work on new data sets that are out of distribution. So that's something that we're spinning up that's very new in post-deployment monitoring of algorithms. But I don't think I have any answers for you. I probably will pose more questions, so maybe I'll stop for now.
So we can look at it from the flip side, just to play off of what you just said, right? So we're talking about through academic side, which is how your question was directed. Yeah. But let's look at the commercialization side. AI is really hard, right? It's about money, it's about IP, it's about commercialization. It's actually about, all the commercialized products we have right now within the medical system. I'm trying really hard not to name the names right now, right? But we've all been there, and they've all asked to come into your institution to provide access to care, to expedite patient, blah, blah, blah. What they're really doing is getting your data, right? So data is gold right now. This is the new oil. This is the new asset that we have and we control, because we own the disease, and by proxy, we have access to the patients. So if you look at it from the commercial side of things, how do they run their business? It's actually all under business licensing, under all IP rights. And when they get into your hospital and they help you to expedite your diagnosis of blah, 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 they're keeping your data. That data is not destroyed and is not going to be returned to you. So just keep that in mind, that that's how they are choosing to do it. Do I say we replicate their model? Probably not. We're not built like that. We don't think like that. But that's the flip side.
Yeah, depending on how you sign the business agreement, right? Yeah, it doesn't have to be that way.
Matt, you had and I'd love to hear as well from Bobby, because you're actually deploying these as well for research. But you and Matt.
I just think of previous disruptive things that have surfaced. Electronic health record, expensive. Now you can't afford not to have it. 3D reconstructions, there's several different proprietary things available. Also, you kind of have to have it now. And I think with this stuff, we got to make it such a win-win and make everybody, the patient and the physician's lives easier, that you just want it by default. I share your concern. I was recently at a meeting where a company that's marketing AI analysis of image data very aggressively. To me personally, for example, there's a physician presenting a research project where they were co-authoring that paper, and it was pretty clear that they had pretty limited involvement in what was done or how. We do have to be careful about conflicts of interest under these circumstances too.
And then the last comment from Bobby.
I think the Kaiser or former Kaiser physicians in the room would agree that the sweet spot in the Permanente group is if you can prove quality improvement, efficiency, lower cost, and then avoidance of risk. Like if you merge all of that, it's a winner. People will come chasing after you to implement these things. You know, you can't always get all of those things together. So any combination thereof, you provide a compelling case, and then the money follows and the resources follow. So what I've learned is in order to implement change, in order to operationalize something, you first have to prove it. They won't come to you and ask you to do that. You have to do it. But once you do, they support it.
Okay, fantastic. I think we'll wrap it up with that. We're 2 minutes over, 3 minutes over. But thank you very much for everything.